Okay, so in chapter 15, we're going to talk about some of the different things that can influence not only the mother, but both parents and the entire family unit as it transitions into parenthood. Attachment in and of itself is a process that parents and the newborn go through, they encounter. It is a process of developing strong affection between the infant, or the neonate or the newborn, whichever term, but the baby and a significant other, such as the mother, the father, even a sibling or a caregiver. Bonding is the close emotional attraction to a newborn by the parents, and this typically is going to initiate and develop within the first 30 to 60 minutes after birth. Terms attachment and bonding are often used interchangeably with each other. Your parents will hold their newborn close right after birth. They're going to interact with him to become acquainted. Acquaintance is a very important step in the attachment process because it's how parents really get to know the baby. They're going to use eye contact. They're going to touch everything they can get their hands on. They're going to coo at the baby, talk, just make little sounds, and explore the baby. Think about your moms who unwrap the baby so they can, look at everything. Attachment is going to occur through a mutually satisfying experience. The parents will investigate their baby, and their baby may smile back. Even though the babies may not actually be smiling, it is still perceived as a positive response. Now, claiming is when the parents identify with their baby. They look at the baby and they will see others in that baby's maybe facial presentation. They may look at it and say, oh, look, you've got grandma's nose, or you've got granddad's chin. Rachel is older now, but, I will look at Rachel and say, oh, you have the Cochrane nose. So it's things that parents will identify about their baby that shows you are mine because I see this in you. It's a claiming process. Now, for most moms, seeing their newborn erases all unpleasantness from the preceding labor and birth. I mean, we talked about that last week. You've got the endorphins and the feel good, and you're so happy. However, there are a few moms that have difficulty getting past the perceived trauma of childbirth. They will claim the newborn through negativity. Yes, he calls me 12 hours of back labor, or, she just tore me up really, really badly. Something in a negative. So as nurses, you can help the mom get through this. You can help her deal with the negativity and promote that maternal-infant bond. If you take your text and you look on page 420, you'll see table 15.3, and there are going to be some examples listed of different nursing interventions to help the attachment. Things such as encouraging mom to hold her baby close to her, perhaps doing skin to skin, even beyond the labor room, assisting in breastfeeding. If you've got a mom who doesn't want to breastfeed, she wants to formula feed, she can still cuddle that baby in a breastfeeding-like hold. Encourage the mom to help with the newborn care, changing the diapers, bathing the baby, changing the clothes, things like that. Being a parent isn't always the easiest thing to do. Regardless of what people may say, we aren't necessarily born with all of the knowledge that we need to do the parenting job correctly right off the bat. So when you're working with parents, observe them for behaviors that indicate bonding between the parent and the newborn. Look, do the parents respond to the baby's cues? If it makes a sound, does it alert them? Do they seem interested, or are they ignoring? Do they hold the baby close, and soothe her? Do you see them, rocking and shushing her? Did they just unwrap him to count all the fingers and toes and make sure everything was there? These are all observations that you can make that will say, yes, my parent is trying to bond with their new baby. All right, so if we know that parenting doesn't always come easy, then what do we need to consider if, as nurses, we're assessing bonding between parents and the newborn? Well, first of all, let's take a look at the parents themselves. Okay, what is their family support like? Did you see a close-knit group of family supporters, or were the parents isolated and alone? And was this their choice or not? How mature are the parents? And if you notice, I didn't say how old they are, but how mature they are. You know, is the mother more worried about herself than the baby? Is the father more worried about watching a baseball game on TV than the baby? How does the baby itself act? Remember, we have to have kind of like a mutually satisfying experience for the bonding to occur. If there were any concerns at the time of delivery, the baby may have to go to the nursery or to the NICU, and the parents would miss out on that golden hour when bonding happens best. Remember, we said that initial 30 to 60 minutes. Hopefully, those of you who have done your OB rotation have been able to see moms take the babies and put them skin to skin almost immediately after birth. Skin to skin within the first 5 minutes of delivery has been proven to facilitate bonding between the mother and the newborn. That newborn is very alert in that immediate delivery time. And because it's alert, it's going to look around. Your baby will meet the gaze of her parents well. Now, while she may not focus as clearly, the parents can still look into her eyes and they can still make that eye contact and form a connection. Rooming in allows for the baby to stay in the room with mom and dad for at least 23 out of 24 hours. For facilities that do not support rooming in, parents are separated from their newborn except for the times that they may call the nursery and ask for the baby, or for when the staff decides it's time for the mom to nurse the baby and the staff will bring the baby into mom. If you don't have a supportive facility and a supportive staff, attachment can be hindered. I want you to review tables 15.1 and 15.2 in your book for newborn and parental behaviors affecting attachment. So let's stop and think about touch for a minute. Picture your mom. She's reaching for baby pretty much as soon as she sees him come out of her. And it does not matter one bit to her that he is bloody, wet, or cheesy either. She just wants to touch him and hold him. Remember I said earlier, parents will look directly into their newborn's face and try for eye contact. Now we refer to this position as in face or on face. The parent and the baby on the same level, faces about 20 centimeters apart. Most parents will begin talking to their baby while the baby's still in utero. So there is some degree of voice recognition after birth that has been postulated. When parents speak to the baby, she will move in rhythm and cadence to the parent's voice. This is something we call entrainment. Babies can differentiate the smell of their mother and their mother's milk from others. When we put the baby in skin to skin immediately after birth, that position and that skin contact will actually transfer the odor of the amniotic fluid onto the mother's chest. And it will serve, I guess for lack of a better word, like a homing beacon to the babies. So when they are there at mother, they can smell that amniotic fluid. They recognize this scent as their own, and it calms them down. Reciprocity and synchrony are seen when the baby cries and the mother soothes and cuddles. Then the baby calms down and makes and holds eye contact with the mom. So we have a mutually rewarding response. Now, becoming parents can be an emotional roller coaster for both mom and dad. You have to remember that she has a whole lot of hormones going on and they're wreaking havoc in her system, And he's probably dealing with some pretty serious insecurities about how to handle and care for such a tiny little being. Their whole family dynamic has just undergone a major upheaval, and the parents are now faced with identifying themselves as parents and what is now the new family unit. You need to remember life outside of their new world continues, and they're going to have to jump back into it. So, how do they manage going back to work? Other family members, friends, relatives who just want to come see the baby, a lack of sleep because they're probably never going to sleep well again, and something as simple as keeping everybody, themselves, the baby, any siblings, simply fed and clean. When pregnant, we all think of our babies as perfect little beings. Unfortunately, that's not always the case. Think about the dad who bought a football when he heard that he was going to have a son, or the mom who may have put her daughter on the wait list for the best dance academy in town, only to discover at the point of delivery that the ultrasound was read as the wrong gender. So you got a dad with a little girl or a mom with a little boy. Or even worse, the baby that they've envisioned as perfect could have had an occult or a hidden anomaly that wasn't detected on the ultrasound. It can be very challenging to accept the child you have as compared to the child you imagined and that you dreamed of. There may even be a sense of loss and a need to mourn over what they never really had, but still connected with so strongly. Now, Mercer introduced the concept of becoming a mother when hospital stays shortened from the previous 3 to 5 day stay that we were talking about in class to what is currently a typical 2 to 3 day stay. Becoming a mother is more than attaining a role through having a baby. Okay? It is a process. According to Mercer, there are 4 distinct stages to becoming a mother: commitment or attachment to the unborn baby, and preparation for delivery and motherhood while she's still pregnant. Then attachment and learning to care for the newborn, as well as a physical return for wellness of her in the 2 to 3 weeks that come after delivery. Progressing towards what will be the new norm for her life, and then achieving a new identity as a mother. So definitely a stepwise process. Well, we all hear about postpartum depression, postpartum blues. What we need to be able to do is to recognize the difference so we can give proper education for and care to our parents and our moms. So, postpartum blues. This is more of your transient emotional disturbances. You're going to have a mom who experiences anxiety, irritability, insomnia, crying, loss of appetite. She's going to be sad. Symptoms typically are going to begin 2 to 4 days after having the baby and will go away by day 8 or so. Postpartum blues will typically resolve with restorative sleep. You got to remember, this is a woman, emotionally labile, hormones whacked out, all over the place, fatigued, worn out, just can't get it together. But if she can get a period where she can just heal and recover through that restorative sleep, typically that's going to resolve. Postpartum depression and psychosis are more serious, and they're going to require a professional referral. Your woman who has postpartum depression, she's not going to be interested in her baby. She's not going to be interested really in herself. Ladies, you got to think about it. If you've undergone some strenuous physical taxing kind of thing, you are going to, if nothing else, want to take a shower, put on some clean clothes, at least put on some clean underwear and wash your bottom, right? Women with postpartum depression, they don't care. They are not going to brush their teeth. They're not going to brush their hair. They're not going to bathe their body. They're not interested. So that's a big difference. Your postpartum blues, they're still going to want their baby. With postpartum depression, symptoms are going to last longer, they're more severe, and they're going to require treatment. It will lead to poor bonding, maybe even alienation from loved ones, and daily dysfunction, and worst case scenario, violent thoughts and actions. So she can hurt herself or the baby. So as nurses, you need to be able to educate parents on the difference between the two, what warning signs to look for, and how to handle any concerns for mom. All women should be screened at their postpartum visit for postpartum depression. However, the signs and symptoms of depression may not manifest by their 6 weeks checkup. It is not an uncommon practice for the baby's pediatrician to observe and to screen for postpartum depression during baby's visits, especially in that first year, because they're going to see mom and baby together very frequently in those first few months of life. All right, so let's take a moment and talk about dad, okay? You got to remember, dads don't have childbirth classes specifically targeted for them, and they don't have any resource really except a few, maybe an internet source, or there may be a chapter in the What to Expect When You're Expecting book. Dads just don't really get a whole lot of help and support. So we need to stop and consider what their role is going to be, okay? They're going to go through pretty distinct, predictable phases just like your mom will, and they've got to figure out how to adapt to, being a breadwinner, being supportive for her, and they're going to need to be adding in and taking on responsibility in the baby's care as well. So it's going to be a bit of an adjustment for them as individuals as well as a couple, okay? And when we talk about resuming sexual activity, we mentioned that the woman is going to undergo some changes, and until her estrogen gets straightened out again, intercourse is just going to be real uncomfortable. But, this is a bonding time, and you can have intimacy without sexual intercourse, okay? This is a time to talk with each other, to spend time with the baby together. Date nights where you just go out and have dinner and reconnect. All right, so big things to look at. For your lesbian couple, unfortunately, they have to stand up to a lot of critique, criticism, and ridicule just because of life choices in a lot of different areas, and it is sometimes hard for people to accept that they are indeed a family unit because they don't adhere to what some societal norms say are your traditional family units, and that's just really, really sad. Thinking about dad, engrossment, that's a term that we typically reserve for the father. They have to have and they will experience a visual awareness of the baby as well as a tactile awareness. And you remember, mom made the eye contact, mom was touching and everything. They may have a perception that their newborn is perfect, okay, and develop a very strong attraction and a good bond to that. They are aware of distinct features of the newborn. Remember that claiming process that parents go through. And they are incredibly proud and happy to be a father. I mean, they recognize this is a progeny and this is carrying on the next generation, okay? And they may have an increased sense of self-esteem because they are not only providing for themselves, but if they are successfully parenting and providing for others, then they are doing something well, doing something good, and that's a self-motivator and will increase your self-esteem. Now, your adolescents, they're still growing and maturing themselves. We have to keep that in mind. While younger mothers are capable of warmth and nurturing, they are less inclined to verbal exchange than the older parents may be. Adolescent mothers tend to use similar parenting skills as what their own mother used on them because that's the closest role model that they have. So you can appreciate it's going to be pretty important to recognize the type of caregiver her mother is or was to give you some insight into the adolescent mother. It's going to be important to include the young father in the teaching and the care of the newborn, as he will often continue in the relationship with the mother and baby even if they're not married. Your older parents may not have had the same level of social and familial support as the adolescent. A lot of your older parents live away from siblings or grandparents, and so they don't have that immediate support of, their mom coming and being with them, or, their siblings being there. There's also the potential of discord between the mother and the father as they are faced with change in what was previously a very well set, well defined, well working partnership and relationship of just two people. You add in this third little person that's just disrupting their entire world, and it can be very challenging. Now, several cultures observe a period of rest and recuperation for the mother after she has a baby. Your Asian mothers, typically they're going to remain at home with the baby for a month, and they're not to do any type of chores or housework, including taking care of the baby. Similar time frames and limitations are held by Japanese and your Jordanian mothers. Your Latinas will practice this recuperation period, and they're going to have food restrictions, and the father is not expected to see mom and baby until both of them have been cleaned up and are dressed and are deemed presentable. Well, what about sensory impairment with our parents? Just because they are visually impaired or hearing impaired, does that mean they're unfit for parents? Absolutely not, okay? But as nurses, we need to be able to recognize what some of these challenges are and be able, to help guidance. If you've got a visually impaired parent, then the infant may very well need sensory input from the other parent to, help the child balance that out. Also, your visually impaired parent will have heightened senses of their own. Think about their touch and their hearing. So they're going to have other sensory input and output that's going to be beneficial. If you have a hearing impaired parent, then you need to, especially thinking in the hospital, what are you going to do to help support them? If you're going into a patient's room and she's hearing impaired and she doesn't see you come in, she can't hear you knock on the door, you don't want to just barge in and startle her or scare her, especially if she's holding the baby or something. So, do something, walk slowly around into her line of sight. Turn the light switch on and off and, get her attention that way. Hospitals are required to support your visual or hearing impaired or any other disability patient while they're in the facility. Section 504 of the Rehabilitation Act of '73 requires hospitals use various communication techniques with the deaf and the hard of hearing. So you can have in Opelika we call it the Ubi Duo, where it's actually a phone that one person can talk into and it can type out. It's going to type out what it's saying. So you've seen where hearing impaired people will actually type into like a typewriter keyboard and it will print the words out on the screen. So there is some way that there is going to be communication and the ability to ask questions, give answers to help your visually impaired or your hearing impaired parents deal with having their baby and getting their education. Braille supplies are provided for your visually impaired so that they can receive their education. We talked about preparing families for having the baby, before the baby comes, such as with your younger children and the siblings, have them be involved with maybe picking out baby names, or letting them, listen to the baby at doctor's appointments. But even if you prepare them, depending on the age of the sibling, you may still see some behavioral changes. One of the most common things that we think about is regression in toileting or sleeping habits of your toddler to preschool. There may be a sibling rivalry. If I've always been the only one, now mommy has this baby at home, and she's always holding the baby, so I can't sit in mommy's lap anymore. You may, have seen or can imagine a toddler or a preschooler taking a pacifier away from the baby or starting to drink out of the baby's bottle because in their mind, that's what it's going to take to get mommy to pay attention to me. So, how do we facilitate, this transition and the acceptance of this newborn? Get them involved with taking care of the baby, all right? Let them hold the baby. Let them, help with diaper changes, whether it's to put the tape down on the diaper whenever you're pushing it closed or not. Let them go through the acquaintance process and the bonding process, the same way that we have fostered for our parents. With grandparents, depending on the family dynamic, grandparents may be, what my grandparents were, just the escalated, honorary, other mother kind of thing that gets to spoil the child but doesn't have to take responsibility for their actions in spoiling the child. Unfortunately, there is increasing numbers of grandparents that are providing direct care to the grandchildren, whether it be raising them, kind of the way my mom did for my nieces, or it may be that instead of sending the kids to daycare, grandma and grandpa are providing daycare services because it's free to the parents for the most part. They trust the grandparents, and the grandparent gets to spend time with the kids. So to finish up this chapter, we want to talk about care management for parents who are transitioning into parenthood. What we are, what we say, what we do in this capacity is directed towards helping them cope. Okay, this is a new process for them. I was 8 years older, or I am 8 years older than my baby brother, and when he came along, I was a big helper to mom. I would change Cecil's diapers. I would feed Cecil. I would rock him to sleep. I would do all these things for my baby brother. But I realized when I had Rachel, I wasn't prepared for how to care for an infant as the primary care provider. So we need to help them understand what all is involved truly with infant care and that responsibility. We talked about their roles are going to change, their relationship, their lifestyle, everything that was in their world stable is just fruit basket turnover unstable. So we need to help them identify the stressors that they may very well experience and what type of coping skills will be useful to help them make that transition and adaptation to becoming a parent. Nurses, your role is to provide education, support, and encouragement. Okay? You're a very, very important part of this transition for them. So we need to take it seriously. All right, so that's the end of chapter 15. If you have any questions, make sure you bring them to class. Thanks.